Hello and welcome to the latest in my ongoing series of document deep dives. And in today's deep dive, I'm going to take you through an article that was published in the Journal of the American Medical Association on February 10th of this year, 2021. This is one of a whole slew of studies that have been published in medical journals in the last couple of months to try to persuade the general public and doctors that wearing a mask is necessary and an effective means of preventing or reducing the spread of SARS-CoV-2, the virus that is associated with COVID-19. So let's go ahead and dig into this study. And in the very first paragraph, they point out that prior to the current epidemic of COVID-19, the efficacy of community mask wearing, that is people just out in the community, not in a healthcare setting, wearing masks to reduce the spread of respiratory infections, was controversial because, and this is actually a typo, this should say there were no solid relevant data to support their use. And if you look at the pandemic preparedness plans that each country holds, and also the documents held by the CDC and WHO giving advice on how respiratory pandemics and epidemics should be handled, you'll notice that in those documents the wearing of masks in the community is specifically not recommended for lack of evidence. Now, they claim that during the pandemic the scientific evidence has increased and that compelling data now demonstrate that community mask wearing is an effective non-pharmacological intervention to reduce the spread of this infection, especially as source control to prevent spread from infected persons, but also as protection to reduce wearers' exposure to infection. So this in essence is kind of like a summary article where they're pulling together the results of these various studies. So going on to this paragraph here, they talk about how community mask wearing substantially reduces transmission of severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, in two ways. Firstly, as source control, that is preventing or reducing the expulsion of the virus by people who are already infected. And why is this important? They argue it's because it's estimated that at least 50% or more of transmissions, that is passing the virus on, are from persons who never develop symptoms or those who are in the pre-symptomatic phase of COVID-19 illness. Now, as a reference to support that statement, they quote this particular study here, study number 1, SARS-CoV-2 transmission from people without COVID-19 symptoms. Now, as it so happens, I actually pulled apart this study in detail in my newsletter article from a couple of weeks ago. I'm not going to read the whole study to you. It's going to be linked in the notes below. But basically, this study here, SARS-CoV-2 transmission from people without COVID-19 symptoms, is an example of what people in the computer programming world call GIGO, garbage in, garbage out. This is essentially junk science. So if you input very, very poor quality data into a model, what you're going to get is basically garbage. And you can read through this study and see how I've basically pulled this apart. Let's just go to the money statement. The evidence that asymptomatic transmission exists at all is tissue thin. So we can kind of dismiss this first reference as being junk science, and citing this in an article which is supposed to be justifying the use of masks is not an example of good scientific practice. Now, the next couple of references are cited to support this following statement. In recent laboratory experiments, multi-layer cloth masks were more effective than single-layer masks, blocking as much as 50 to 70% of exhaled small droplets and particles. Now, it's important to point out that these were laboratory experiments, so these weren't done on actual people to see whether wearing a mask prevented people from spreading their germs around and prevented other people from getting sick from said spread. But let's go and have a look at these two articles. So references 2 and 3, efficacy of face masks, that's this one here. And what they found is that while an N95 respirator, the sort of protection that people in hospital settings or laboratory settings when working with viruses might wear, that was pretty effective. It actually blocked 99% of the aerosols, the little tiny particles that are expelled when one simulates a cough, and that's what they did here. They actually set up some dummies and a cough simulator. A medical grade procedure mask blocked 59%, a 3-ply cotton face mask blocked 51%, and a polyester neck gaiter blocked 47%, or if you doubled it, it was 60%. And a face shield blocked only 2%. So those plastic face shields that you see people wearing are basically useless at preventing transmission of cough aerosols. But again, the really crucial take-home message from this is that these were simulated cough-generated aerosols. So this isn't actually studying the process of spreading the virus in a real setting. And the next reference, effectiveness of face masks in preventing airborne transmission of SARS-CoV-2, that's this one here. Similarly, this was an experiment in which they got 2 dummies and simulated airborne transmission of infectious SARS-CoV-2 containing droplets or aerosols. Now, actually, I forgot to mention in this one, they didn't actually have any honest-to-God virus. They were just like measuring the dispersion of aerosolized particles that a person might cough out. But this wasn't an actual person. It was a cough aerosol simulator with a pliable skin head form, a dummy that they set up to simulate a cough, basically. Now, in this one, they actually got some real live SARS-CoV-2 virus and measured how much of it got spread around. But there were some very interesting aspects of this which I wanted to go through. So 2 of the important things that they were measuring were viral loads and what they described as infective virus. And in this section, they describe how they measured viral load through means of a plaque assay, which is a perfectly sensible way of assessing viral load. But their method of assessing infective virus was a PCR test. And as I think most people who haven't been living under a rock for the last year or so will know by now, the PCR test is actually incapable of detecting infective, which I presume they meant by that infectious virus, as was stated by the scientist Kary Mullis, who won a Nobel Prize for inventing the PCR technique. So this is so running a PCR test is not a valid way to measure infective virus. In order to measure whether the particles that you have detected are actually capable of infecting a cell. And that's the only way that a virus can cause harm, by the way, is if the virus can actually get into the cell, hijack its cellular machinery, and use that machinery to make more copies of itself. The only way that you can determine whether what you've detected through your PCR test is actually capable of infecting somebody else is to do a cell culture assay, which they did not do. So they were using the wrong test to assess whether what they were actually picking up was infective virus. And they also pointed out that although the efficiency of detecting infectious virus was reduced when the amount of exhaled virus was reduced, viral RNA was detected regardless of the type of mask used. So basically what they're saying is that even with the most effective mask that we know of, which is a properly fitted N95 mask, some viral RNA, some genetic material of SARS-CoV-2 did actually get through. Now, again, they weren't measuring whether that virus was capable of causing infection, but the point is that if you have a PCR test done, and that PCR test is set to a cycle threshold really anywhere above 35, probably even above 25, it's highly likely to pick up on tiny, infinitesimally small amounts of the genetic material, the RNA of SARS-CoV-2. Does that mean that you're infected? No. Does that mean that you're infectious? Absolutely not. Does it mean that you've been sick or will get sick? No. It just means that viral particles were detected in the part of your body where the swab was taken from, say up your nose or at the back of your throat. So again, what does this study actually show you about mask use and whether it stops people from getting sick in the real world? Precisely nothing. Nothing whatsoever. Right, let's go back to our JAMA article and we'll go to the next paragraph and the next reference. So they claim that masks protect uninfected wearers by forming a barrier to large respiratory droplets, etc., etc. The observed effectiveness of cloth masks to protect the wearer is lower than their effectiveness for source control. So again, that references study number 3, this one here, which, as I've pointed out, has basically zero relevance for real world situations in which we are trying to ascertain whether wearing a mask might protect somebody else from actually getting sick. They talk next about epidemiological investigations, in other words, studies conducted out in the real world in populations that have helped quantify the benefits of mask wearing to prevent the spread of SARS-CoV-2. And here's the table that they say provides evidence for this. Now, so the studies that they claim demonstrate that wearing a mask reduces infection risk. First up, here we have an anecdotal report in which 2 hairdressers who were infected with the virus and had some symptoms cut the hair or styled the hair of 139 people who went to a salon, and lo and behold, there were no COVID-19 infections among the 67 patrons who were available for follow-up. Now, those were the ones who were available for follow-up. Who knows what happened to the remainder of the 139? I mean, if you're actually citing a study in which 2 hairdressers said, yeah, we wore a mask and none of our customers got sick, that's not exactly a high level of evidence. That is basically an anecdote. This next one is a study of 382 US Navy service members serving upon the USS Theodore Roosevelt, which docked in Guam. And let's go ahead and take a look at this study in detail. So here it is: SARS-CoV-2 infections and serological responses from a sample of US Navy service members. And what do we find out? Well, in late March 2020, this aircraft carrier, the Theodore Roosevelt, arrived in port after numerous of the service members on board developed COVID-19. And then the following month, the US Navy and the CDC investigated this outbreak. So the first thing that you need to understand is that this investigation was basically retrospective. They waited, and obviously they had to wait until the ship got into port. But by that stage, a number of service members had already got sick. They had a cold or sneezed or whatever. And it was only after this had happened that they took what they call a convenience sample, 382 service members of the approximately 1,800 service members who were on board. So again, that's a reasonably small slice out of all the service members aboard the aircraft carrier. And they they gave them a questionnaire asking them whether they had worn a face covering, avoided common areas, observed social distancing, and they also checked them for protective antibodies. Now, anyone who has even the most basic knowledge of study design knows that there are serious limitations with retrospective analyses, and one of the primary ones is recall bias. That is, when a health event has already taken place and you ask people to describe their behaviour before and leading up to that health event, their recall of what happened and how they behaved is altered by the fact that the event has already taken place. In other words, people who were, say, sharing a cabin with someone who developed symptoms and then was found to test positive to SARS-CoV-2 are very, very likely to have different recollections of their behaviour. For instance, they might be more or less inclined to report that they were keeping a distance from the person who was sick, or whether they were wearing a mask or whatever have you. So this is why retrospective analyses are not considered to be as high a level of evidence as what's called a prospective study, which is where you set up a study in which you're going to examine the likelihood of a health event occurring in the future, and you basically exert pretty tight control over people's behaviour. And just such an analysis was done in a military setting, published in this particular study, SARS-CoV-2 transmission among Marine recruits during quarantine. So this was a prospective study. What they did was they took a bunch of US Marine Corps recruits and they put them through a pretty intense quarantine protocol. So here's what they did to these people. Those who enrolled in the study were ordered to wear, and they were military recruits, so one can imagine that their following of orders was higher than in the general community. They wore double-layered cloth masks at all times, indoors and outdoors, except when sleeping or eating, stayed 6 feet away from each other, weren't allowed off the campus, weren't allowed to basically touch any objects that might contribute to surface transmission. They washed their hands, they slept in double occupancy rooms with sinks, ate in shared dining facilities. Doesn't actually say it here, but their meals were pre-plated so that they weren't actually touching any serving equipment. And when they went to the bathroom, they sanitized the bathrooms after each use with bleach wipes. Oh yes, here's the pre-plated meals bit. The dining hall was cleaned with bleach after each platoon had eaten. Their exercises were conducted mostly outdoors. They had these recruits move in and out of buildings in a unidirectional fashion to minimize contact. All of them had daily temperature checks, symptom screening. The instructors worked 8-hour shifts. They were also they enforced the quarantine measures, and they were placed in isolation if they developed any signs or symptoms. So this was basically literally a military level quarantine. And so what happened? Well, what happened over the course of the study was that by day 7, out of 1,801 participants who tested negative to SARS-CoV-2 at enrollment, 1.3% were positive on day 7, which is about the level of positivity rate that you see in the general community, despite this incredibly strict quarantine. And 35 participants who had negative PCR results within the first few days after arrival became positive during the supervised quarantine. So the virus was still passing around despite all of these extraordinary quarantine measures. So a 1.7% positivity rate by day 14. Now, it is important to note that the symptoms were exceptionally mild, and that's true, by the way, of the supposed outbreak on the Theodore Roosevelt. So relatively mild symptoms, asymptomatic infection. I mean, these are young, healthy military service persons or military recruits, so their risk of actually getting seriously ill is very low anyway. But the virus certainly managed to spread itself around despite all the masking and the other attempts to reduce the transmission of it. So as Alex Berenson has famously said repeatedly on Twitter, virus gonna virus. This is a respiratory virus. It's highly contagious. If you think that wearing a mask and washing your hands and keeping 2 meters or 6 feet or 1.5 meters or whatever the heck distance away from other people is going to prevent the spread of this virus, you are absolutely categorically wrong. And so you've really got to ask yourself, what are we doing mandating masking or any of these other measures in the community when when all of these measures are enforced with military discipline, it doesn't actually achieve the desired outcome. Now, just going back to a couple of the other studies that were cited here. So we've got this one conducted in Bangkok, and that's this one here. And once again, the weakness of this is that it is a retrospective case control study in which people whose family member were tested positive for SARS-CoV-2 and entered quarantine were asked whether or not they wore a mask. And what case control means is a case in this particular instance is a person whose family member tested positive for the virus and then the case subsequently tested positive, and a control was a person whose family member had tested positive but they did not test positive. And again, they were asked to remember how they behaved when around the family member who tested positive, and same limitations apply as discussed previously. When you're doing a retrospective study, people remember things differently depending on whether in this case they got sick themselves or whether they tested positive themselves or not. So very, very weak study design. Similarly, this report of households in Beijing, China, that is this one here. Once again, it is a retrospective cohort study. So basically, you've got a whole table here. I won't go through all of the others, but you've got a whole table here of studies with an amazingly weak study design. And what they failed to cite in this study is those with a strong study design, like the study of military recruits, which I just showed you. Now, one of the other studies that they cite is this one, number 7, and that's community use of face masks and COVID-19 evidence from a natural experiment. So here we go. Now, this one claims that in counties in 15 states, those counties that actually mandated face mask use in public saw a decline in the daily COVID-19 growth rate by these percentages. So again, I mean, these are not exactly huge declines in the growth rate of COVID-19. However, this study was published back in June, whereas the study that cited it was published in February. And so there's a lot more data that's come in the meantime, and some of those data are actually summarized in these mask charts. There's some great collections of mask charts, but let's just have a look at two collections from Rational Ground, which is amazing. So here we go. Israel is represented by the blue line, Sweden by the orange line. Sweden has never actually had a mask mandate, and you can see here they had a spike in cases, and then it's dropped off in the absence of any mask use. And then Israel, you can see here where they instituted a mask mandate, and then they upped the enforcement of it, and you can see that the virus continued to spread, and in fact its rate of spread increased dramatically over time. Now, it's true, it's very important to point out that the increase in supposed spread of the virus, this doesn't reflect illnesses, by the way. It represents the number of people who've actually tested positive, and this can be affected by the number of tests that are actually carried out. But the testing rate, or the number of people tested, has not varied terribly much in the last several months. So when you see this huge spike in test positives, you can see very clearly that the mask mandates are not actually working. And you can go through and see, here's Miami-Dade County in Florida, here's where they implement the mask mandate, and then they have this big spike in cases. Hawaii mandated masks inside here in April, and then made it mandatory outside in July, and their cases continued to go up. Here are 4 different counties in California that implemented mask mandates at different time points. And what's interesting about this one is that the virus basically spread at pretty much the same rate, regardless of where mask mandates were introduced or what time point they were introduced at, which, again, going back to Alex Berenson, virus gonna virus. If you've got a highly infectious respiratory virus, it's just going to do its thing and spread around, no matter how many masks you're wearing and how far you're keeping away from people and all this other stuff. Now that should say mask mandate, not mask vaccine, but you can see here that the spike in COVID deaths in New York was already well and truly on its way out. The rate of the number of new deaths was declining by the time the mask mandate was introduced. And you can go on and have a look at all these other mask charts. Philippines is interesting. Their mask mandate was enforced literally at the point of a gun, and you can see how much good it did. The virus continued to spread. And okay, so what about mask mandates outside of the US? And you can see here that in Europe, as in the US, no matter what time point that masks were introduced, it's had basically zero effect on the number of cases. And have a look where the number of cases starts to rise. It's exactly where you'd expect it would be, which is as the weather cools down and respiratory viruses begin to spread again due to reduced humidity and reduced air temperature. And so once again, no matter where each country introduces its mask mandates, you see basically the same trajectory of the virus. Okay, so France and Germany got in pretty early with this. Spain took a while. The UK took even longer. The shape of the charts is pretty much the same. Okay. So this is an interesting comparison of states that had mask mandates versus those without, and what they found was that in states that had no mask mandate in place, there were 17 cases of SARS-CoV-2 positivity. Again, not necessarily sick people, but people who tested positive per 100,000 people. And those states that had mask mandates in place, there were 27 cases per 100,000 of people, right? So again, there's just a total lack of evidence that mask mandates achieve anything useful at all. And why would that be? Well, back in 2003, when SARS, the first SARS, severe acute respiratory syndrome virus 1, just called SARS back then, was spreading around, there was a lot more sense spreading around as well. And Reba Ma, who was the Fair Trading Minister for New South Wales, got hot and bothered because pharmacies were selling masks, and some of them were promoting the idea that wearing a mask would protect you against getting SARS. And she said that that distributors and traders could be fined if they were caught telling the members of the public that masks actually gave protection from SARS. So health authorities have warned that surgical masks may not be an effective protection against the virus. Those masks are only effective so long as they are dry, said Professor Yvonne Cossett of the Department of Infectious Diseases at the University of Sydney. As soon as they become saturated with the moisture in your breath, they stop doing their job and pass on the droplets. Professor Cossett said that could take as little as 15 or 20 minutes, after which the mask would need to be changed. So how times change, 17 years ago, nearly 18 years ago, our health and medical experts were saying these masks, I don't know what people are doing wearing them. Not only are they not effective, but they may actually make things worse, because once they get saturated, there's actually a higher risk of these virus-filled respiratory droplets being expelled from the mask. Now, in contrast to this JAMA article, here's what Tom Jefferson and Carl Hennigan from the Centre for Evidence-Based Medicine at the University of Oxford had to say about the lack of solid evidence for the protective effect of face masks. And in discussing the meta-analyses that have taken place in the last couple of years, what these meta-analyses, which is like a study of studies, what they show is that masks alone have no significant effect in interrupting the spread of that's influenza-like illness, influenza-like illness, or influenza in the general population or in healthcare workers. One study found that influenza-like illness rates were 13 times higher in Vietnamese hospital workers who were wearing cloth masks compared to those who were wearing medical or surgical masks. And those who were assigned to wearing cloth masks actually had over 3 times higher rates of influenza-like illnesses when compared to hospital workers who weren't wearing masks at all. And that particular Vietnamese study is this one here, published in the BMJ Open, and again here are the numbers. So wearing a cloth mask actually caused these Vietnamese hospital workers to have higher rates of influenza-like illness than those in the control group. And even after adjusting for other factors, there was still a nearly 7 times greater risk of influenza-like illness in the as well as a nearly doubling, so 1.72 times the relative risk of hospital workers becoming sick with laboratory confirmed influenza if they wore cloth masks compared to those wearing medical masks. And Jefferson and Hennigan point out that it would appear that despite 2 decades of pandemic preparedness, there is considerable uncertainty as to the value of wearing masks. That is, honest scientists recognise that at this point we do not have enough evidence to make definitive statements about masks providing protection, either as methods of source control or protection from people wearing the mask from getting sick. They mentioned that recent reviews using lower quality evidence found masks to be effective, and that's what we're seeing in this article from JAMA. It's very low quality evidence compared to the quality of evidence that's actually informed the meta-analyses that Jefferson and Hennigan are discussing in this article. And these recent reviews using lower quality evidence that found masks to be effective have called for robust randomized trials to inform the evidence for these interventions. In other words, even those who wrote these evidence reviews using low quality evidence and saying, it looks like on the basis of pretty poor quality data that they might be effective, but we're not going to say that definitively. We're going to say you got to run proper trials on this before you make recommendations. This was an interesting piece. Norway's Institute for Public Health reported that if masks did work, then any difference in infection rates would be small when infection rates are low, which is what we're seeing in most parts of the world now, including Australia. Assuming 20% asymptomatics and a risk reduction of 40% for wearing masks, which is actually highly unlikely, 200,000 people would need to wear a mask to prevent one new infection per week, right? So all of the negative effects of mask wearing, the mask knee, these horrible facial conditions that people are getting from wearing a mask all day, the re-inhalation of their own exhaled carbon dioxide, the dental problems, the problems with tooth decay that dentists are now identifying, all these issues that are besetting people because of wearing masks. And what's the good of it? 200,000 people wearing one to prevent one new infection per week. What is the point of this? And Hennigan and Jefferson state that the small number of trials and lateness in the pandemic cycle, that is, the studies, the good quality studies or the well-designed studies that are either currently going on or have already taken place and reported their findings, are very late in the pandemic cycle. That is, these trials are going ahead at a point where the virus has already gone through the population, and there's really just the leavings of it to study at this point. And because of that, it's unlikely to give us reasonably clear answers and guide decision makers. This abandonment of the scientific modus operandi and lack of foresight has left the field wide open for the play of opinions, radical views, and political influence. And that's really why they call their article Masking Lack of Evidence with Politics. That's what we're seeing. Mask wearing has become a political issue because of the abandonment of the scientific method, proper scientific technique to actually investigate the question of whether masks actually work or not. Now, the next point made in the JAMA article is basically dismissing any potential harm that might be done, particularly to children, because they're unable to make accurate inferences about the emotions of others when the lower half of people's faces are covered with masks. And so the citation for this point, number 8 here, is this study, Children's Emotion Inferences from Masked Faces. Let's go over there. And in this one, they exposed children to a variety of images in which people's faces were either uncovered or the lower half was covered or they were wearing sunglasses. And then they asked the kids, or basically ascertained whether the kids could identify emotions. And they concluded that children were less accurate with faces that wore a mask compared to faces that were not uncovered. That is less accurate at determining the emotional state of people. And remember, these weren't real people, these were just photographs. And they concluded that children's social interactions may be minimally impacted by mask wearing during the COVID-19 pandemic. It is a pretty far leap to go from getting a bunch of kids in a room and showing them photos of people with various parts of their faces covered and finding out that they can still, kind of guess what emotions people are experiencing, to conclude that their social interactions are not going to be impacted by mask wearing. I think I'd want more convincing evidence than that. They state that it appears that masks do not negatively impact children's emotional inferences to a greater degree than sunglasses. Well, I don't know about you, but I don't normally, I don't recall having, for instance, teachers when I was in school wearing sunglasses in class, or having my peers wearing sunglasses all the time when I was interacting with them. So that statement doesn't exactly reassure me. But in any case, what they're saying is, hey, don't worry about the kiddos and all this mask wearing. They're going to be fine. Okay, so, but this impact on children's emotional inferences and on their social interactions, while it is very important, and again, I don't think that this study in any way, shape or form proves that there's no psychological harm to children, that is just one aspect of the harm that can be done to both children and adults, for that matter, by wearing a mask. And so again, back to our JAMA article and the next reference, and they talk about concerns about reduced oxygen saturation and carbon dioxide retention when wearing a mask, that these have not been supported by available data. The reference for this, study number 9, effective face masks on gas exchange, and here's this one. And I'll summarize this article by saying they looked at the gas exchange in people with chronic obstructive pulmonary disease. And so what they were looking at in these people with lung disease is basically the amount of oxygen and carbon dioxide that they were inhaling and exhaling before and after a 6-minute walk. And as interesting as that study is, and it's reassuring that people with chronic obstructive pulmonary disease did not show significant differences in gas exchange while wearing a mask, again, that is just one small slice of how wearing a mask affects breathing. And there was an excellent discussion on this that was presented by 2 experts who were OSHA certified, OSHA being the Occupational Safety and Health Agency of the United States, and this interview was presented on the Highwire. And let's take a listen to what 2 people who are actually trained in implementing safe mask wearing in various workplaces, including hospital settings, have to say about the impact of wearing masks on our breathing and in particular on carbon dioxide levels.
Also, within my career field, I used to work in hospitals, and I've sat on numerous infectious disease boards. And what I did is I sat and educated nurses, doctors, surgeons on how to deal with flu outbreaks, the SARS outbreak. So I knew, yes, there's something called the hierarchy of safety and controls. We have the engineering standards, there's work practices that you change. PPE is a last resort. But when you're dealing with infectious disease patients, these are not the masks that you wear. Even N95s are not fully rated to protect against a virus. These micron sizes, again, they're not rated by the National Institute of Occupational Safety and Health. They're not approved for this use. So not only is this a bad idea, there's numerous studies for years based off of the flu outbreaks across the world several years ago that not only do these ear loop masks and cloth masks not work, they are increasing the spread through fomite transmission, which is a form of cross-contamination. You're touching your face. No one is trained on when you're supposed to change these out. No one is trained that when they're soiled or you're working in a humid environment. These things increase the spread. You re-inhale your exhausted gaseous waste, and you can increase your viral load. So if you are ill, not only can you continue to spread it, because you're not understanding the hand hygiene aspect of that, but you will be sicker longer.
Speaking of inhaling your own gases, I actually did a video with my son Ever. For anyone that might have missed it, I got false flag information, false information. This is not how you do this, but let's just revisit that moment. This is my son Ever when we tested the masks on him. This is my son Ever. Ever's 11 years old, and here in Texas, the mandate right now is that 10 and over have got to wear a mask. Ever has to wear a mask wherever we go, and so we bought this thing this week. This measures the amount of CO2 that's in the air. Can we just look at the OSHA numbers? Carbon dioxide levels and potential health problems are indicated below. From 250 to 350 is the background normal outdoor level, 350 to 1,000 ppm typical level found in occupied spaces with good air exchange, 1,000 to 2,000 level associated with complaints of drowsiness and poor air. Obviously, I don't want ever to have drowsiness or poor air. 2,000 to 5,000 level associated with headaches, sleepiness, and stagnant, stale, stuffy air, poor concentration, loss of attention, increased heart rate, and slight nausea may also be present. And then 5,000 ppm or more. This indicates unusual air conditions where high levels of the other gases also could be present. Toxicity or oxygen deprivation could occur, meaning do not hit 5,000. All right, here we go. Right now we're at 848. So I'm going to go ahead and just insert this right like as he did, right underneath, and try and keep it. That feels pretty tight right there, right? Mm-hmm. Okay, so you can just breathe naturally. Let's just see what happens. Okay. All right, so we're at 1,367. We've already just passed 2. So now we're in the place where he could be having headaches. He can be, we're at 3,786. Look at this. We've just passed 5,000. Now we're in the toxic level. Right now we could be doing this 7,000 inside this mask of the CO2, 8,000 parts per million. And now this thing's gone off the Richter scale, folks. Deep, calm breathing. I think we got the idea right. So we've hit 2,000, which is now we know is not safe for any school or any workplace environment. 4,000. Now we're going over 5,000. Now we're into what's known to be a danger zone, 6,000. Parts per million, CO2, 6,600. This is a cloth mask. I thought when I was wearing a cloth mask that this was actually safer. So up in the 9,000s with both of these masks. Upper 8,000s. Unbelievable. So in that video, all we did, now number one, it said false information. That Dell is saying that it reduces the oxygen wearing a mask, and that's not true. Now, number one, I didn't have an oxygen monitor. So they were wrong right there. I didn't buy an oxygen monitor. I bought a CO2 monitor. I mean, we went online, we found a good CO2 monitor, we stuck it up in the mask. Now, I can say, and then I saw arguments, well, he didn't have it there long enough. If you watch the first mask he's wearing, he's there for over a minute and a half, 2 minutes, and it just keeps going. The CO2 goes off the charts. I mean, we go above 10,000 parts per million, so the monitor couldn't register it any longer. But, I mean, I get it. I'm taking the monitor, I'm just sticking it up under the mask. Did I just get an incorrect reading? Is that not how you would do this?
No, we saw that and we were like, he's doing it right.
Del, you did it exactly right. In the world of industrial hygiene, and I'm a senior industrial hygienist, when you are going to test breathing environments or hazards that can be inhaled, you test in the breathing zone. The pulse oximeter test is dealing with oxygen, blood gases, and it just blows my mind. You did it exactly how we're trained to do it in school and out in the field. That is what you do, and the type of meter that you had is instantaneous. And it's designed to be instantaneous because a lot of times those meters are used in confined spaces where you have oxygen deficiency and you immediately have to know. And another aspect of that is you don't even need to do the meter test. The studies have been around since the 1970s that yes, masks can decrease oxygen by 20%. This is exactly why prolonged mask use is not approved in the workplace. If you were to wear a mask 8 to 10 hours a day, like some workers, that goes against OSHA law, and you have to implement work rest cycles. They're not allowed to be in masks this long because we already have the data that shows prolonged mask use is unhealthy.
So there you have it, prolonged mask use not healthy, and this idea that, oh, don't worry, there's no problem with having kids in school wearing a mask all day because they can still read people's facial expressions, and don't worry about this reduced oxygen saturation thing because we've cited one study on a small group of people with COPD. Let me see, there were 15 veterans. Okay, so 15 people. That's how many people this particular study that they're citing as evidence that concerns about reduced oxygen saturation and carbon dioxide retention are unsupported. That's how many people that claim is based on. I mean, really. JAMA is considered to be one of the top 4 medical journals in the world in terms of its scientific reputation. And it's pretty stunning that an article like this that makes claims about oxygen saturation and carbon dioxide rich, I mean, among the other claims that are written in here, that are supported by such poor quality data, I don't even know what to say. This is not good quality science. Now, interestingly, after having cited basically a bunch of pretty junky studies, they then go on to pretty much dismiss one of the very few studies that was actually set up to detect whether mask wearing was actually effective. And they claim so this is the JAMA study, which we'll take a look at in a sec, but they claim the study was far too small, having just cited a study of 15 people with 15 controls, to assess the community benefit achieved. So here's the JAMA study, and what they found in this study, in which they randomized about equal numbers of participants to either wear masks or not wear masks in a particular community. And they found basically that there was almost no difference in infection rates, and infection being defined as testing positive for SARS-CoV-2 between them. So again, primary outcome occurred in 1.8% of people wearing masks, 2.1% in the control group. So there was 0.3% of a percentage point in difference in your likelihood of testing positive for SARS-CoV-2. And they weren't measuring in this study whether people were actually sick. They were just tracking, who tested positive. Again, using a PCR test that is not fit for purpose as an indicator of whether a person is actually infected or not. So after they excluded people who didn't comply, the results were much the same. So excluded participants in the mask group who reported non-adherence, but again, basically no difference between those wearing the mask and those not. And they also found, and this was interesting, that in terms of testing positive for other respiratory viruses, the infection rates were much the same. So whether you wore a mask, whether you didn't wear a mask, there was like 0.1% difference in terms of, for instance, testing positive for influenza or any other kind of respiratory virus. So this claim that the flu has gone away because people are wearing masks, well, no, not according to the only very well conducted prospective study of mask wearing versus not mask wearing that has reported its results so far. Very interestingly, the researchers stated that their findings are inconclusive, that's fair enough, and cannot definitely exclude anywhere between a 46% reduction of infection rate to a 23% increase in infection rate of mask wearers in a community setting. So that's quite an admission to make. It may reduce your risk of becoming infected. Remember, this is what's called a relative risk, which always looks better on paper than an absolute risk. The absolute risk, as you could see before, was like a 1 percentage point. But it may actually increase the risk of infection in a community setting. So again, very telling that the only study really set up to try to answer this question that has published its results so far is pretty much dismissed by the authors of this particular article. Now, if you want an excellent summary of the state of evidence that's very, very up to date, this was published on February 11th of this year. This article, published on the website of the American Institute for Economic Research, is a long one. It's extremely well documented. You can see all the links here, and if you just scroll through some of this earlier bit, you will see this section on the evidence on masking, and it cites really good quality studies And the World Health Organization's previous advice quotes the statement by Yvonne Cossett, which I showed you before, which was printed in the Sydney Morning Herald back in the first SARS outbreak in 2003. It links to the Oxford Centre for Evidence-Based Medicine page, which I showed you before. And again, lots of good links for you to follow up on to really familiarise yourself with the state of knowledge about wearing masks and whether it is or is not protective. And let's just summarise by saying there remains insufficient evidence to demonstrate that wearing a mask, really of any sort, is helpful for prevention of a respiratory virus in a community setting. And back in May of last year, this article was published in the New England Journal of Medicine, another of those top 4 most esteemed medical journals in the world. And it contains some fairly juicy bits. So back in April of last year, it was a non-controversial statement to make that we know that wearing a mask outside healthcare facilities offers little, if any, protection from infection. That wasn't a controversial statement to make. It's become controversial since then, but not because there's really definitive evidence to challenge this statement. Public health authorities define a significant exposure to COVID-19 as face-to-face contact within 6 feet with a patient with symptomatic COVID-19, that is a person who is, for example, coughing or sneezing, that is sustained for at least a few minutes, and some say more than 10 minutes or even 30 minutes. The chance of catching COVID-19, by the way, you can't catch COVID-19, you can be exposed to SARS-CoV-2, but SARS-CoV-2 is the virus, COVID-19 is the disease. It's a bit sad that people writing in a medical journal confuse those two when writing for a medical audience, but there you go. The chance of catching COVID-19 from a passing interaction in a public space is therefore minimal. In many cases, the desire for widespread masking is a reflexive reaction to anxiety over the pandemic. And another very interesting statement, masks are not only tools, they are also talismans. So in other words, kind of like a St. Christopher's medal, a good luck charm, like a 4-leaf clover, that may help increase healthcare workers' perceived sense of safety, well-being and trust in their hospitals. So they're basically acknowledging scared, anxious people are likely to, seize onto the idea of wearing a mask in the same way that, say, a person of the Catholic faith who is nervous about driving might feel better if they hang a St. Christopher's medal over their rear view mirror in the car. So what have we got here? What we've got here is an extremely poor piece of medical/scientific writing that cites other studies and papers that are also of extremely poor quality, and the conclusions drawn from this simply don't carry the weight to properly inform public policy. Okay, so there's my latest deep dive, and please let me know in the comments below what you think. Share this around to friends, family members, random people in the street if you think that they would be interested in learning more about this, and keep on sharing ideas for other documents or studies that you'd like me to analyse in future.